thank you very much. I was a fellow here in Lyon now, so it's always a pleasure to be back. I'll talk to you a little bit about balancing the flexion and extension gaps. I will take you through the workflow I use, and there's going to be some overlap with the previous speakers, but I think that is of importance. So the problem with revision surgery, it's challenging surgery. I think we all agree. That's why we're here, and we face a loss either of bone or ligaments or a combination of both. And you can see some of these typical indications you will have in your office coming in for a revision total knee arthroplasty. Now the challenge is that we are discussing balancing both the height of the flexion and the extension gaps, and we're balancing also the ligaments, the medial and the lateral stability. If you have issues with one of two, you will increase the constraints of the implants. I will take you through my surgical technique because this is of importance. I always use a parapatellar arthrotomy. You do an extensive synovectomy. You remove all of the fibrotic tissue, including Hoffa fat pad. You thin the quad tendon, the extensor apparatus, and then you move to open up the suprapatellar pouch with regine and scissors, which is the Judet release. You evert the patella, and you perform an aggressive peripatellar debridement, including the lateral retinaculum. This is obvious and straightforward approach in the exposure. It has been discussed before, but I think it's very important. You do a meticulous soft tissue release on the medial side to have access to the joint and to remove the implants. And then I have a very low threshold either for a quad snip or a tibial tuberosity osteotomy, especially in the Bacha cases. And then you start removal of the polyethylene, femoral, and the tibial component. By doing this, you're already 30 to 45 minutes, maybe an hour into surgery. That makes that you have only an hour to actually perform the surgery you're supposed to be doing. And so it needs to be efficient, it needs to be quick, and it needs to be safe. I think in revision total knee arthroplasty, you should always start with the tibial first, and you prepare a very nice flat tibia with a keel, and you move forward to the next stage. Next stage, there are some tricks, and I will try to share them with you. Femoral canal preparation. Make sure you enter the femoral canal centrally. Take into account the bowing of the femur. Look into your x-rays and assess the bowing of the femur, because I think this is very important. And I try to enter my reamer a little bit more posterior. And if you have issues with the cortical bone in the back, please take down some cortical bone that will allow you to go a little bit deeper, a little bit more in flexion, and this increases the posterior offset and decreases the anterior buildup, which is in my area one of the main reasons for revision is oversized femoral components. You need fluted stems, of course, otherwise you have some issues. So this is a typical situation where if you do not position your implant in this way, you will have a little bit more extension, you lose posterior offset, and you have anterior buildup. So I don't think that is the good position. Rather, take it a little bit more in flexion. This will give you a certain point of advantages. Then you start femoral sizing the implant, and I think essentially is that you need the medial lateral reference point. We didn't discuss this before. I think this is essential to have a good size of the femoral component and use medial lateral rather than anterior-posterior. This will avoid, of course, also overhang. Again, in my area, that is the number one for revision, or at least a very frequent reason for revision, is overhang of femoral components. So use this by using your femoral component itself or the cutting block. Now modern cutting blocks have the same size as a femoral component, and you appreciate the medial lateral size, which will fix your femoral implant. Despite the big defects very often encountered in revision surgery, these references are often there and they kept safe. If you use anteroposterior referencing, this is less valid, and I think very often that's where we lose offsets, that's where we create joint line issues. So the AP sizing is less valid or less reliable than the ML sizing. I do a minimal refresh cuts, and maybe you have to include at this point some augments to keep that joint line. And then you go into femoral rotation. Michael shared already this with you. There's the bony references you have to include. There's the ligament references that you have to include if they are okay, if you're not dealing with an laxity. I think very important, very easy and handy is to use a knee balancer, a positioner like this, because that allows you to have a femoral that is floating in the air. So if you distract that allows you to really have a nice evaluation of the gaps in flexion and into extension, and this is what is called the hybrid technique, combining both bony and soft tissue references to set that rotation. Then you do the AP cuts. You introduce any offsets or posterior augments if necessary to ideally position that implant. I prefer, again, manual distraction in combination with laminar spreaders. For those of you that use horseshoes like this very often, that pushes your intramedullary rod anteriorly, and you create, again, some issues. So I try to combine this with the manual distraction in case of any laxity. So this creates that rectangular flexion gap of a set number of millimeters, and then you can move forward and you move the flexion gap to the extension gap. I think that is a very easy and very fast and reliable technique. There are some tricks that I will share with you. So at this point, you have the flexion gap, which is either nicely balanced and is set. You introduce your tibial trial, your femoral trial of the ml size that you determined previously. You introduce your trial polyethylene, and then you move progressively from flexion to extension, and your femur will slide, as you can see here. It will slide proximal because of the tension built up in the ligaments, and it will also set at this point the distal femoral joint line. So this is the straightforward approach. You can then go back to flexion, and you will identify that there is a gap. In some of these cases, you can introduce augments of 5, 10 millimeter, or 4, 8, and 12 millimeters, depending on your system that you are using. So the extension gap at this point is adapted to the flexion gap. Of course, you have to avoid hyperextension. This is fast, this is easy, and this is pretty reliable. Additional checks of correct restoration of that joint line is, for me, a very nice trick, and I call this my little secret reference. Nobody talks about this, but very often, even in the worst case revision system or the worst case revision, you always have this posterior corner that is very often well kept and safeguarded during extraction of implants, etc. So if you reduce or if you return the joint line with a correct femoral augment, you can have a restoration of this corner, while if you position an implant and you proximalize the joint line, you're going to have this. And that situation is felt. You can see that, and you can feel that with your finger. So that's an easy and pretty reliable secondary landmark for the correct joint line. Alternative steps in this situation is, of course, you can go first into extension, then copy that into flexion. I think we all discussed that there are a number of variables, especially on the joint line. And these are all means and averages. And I think the first thing that I learned in orthopedic surgery that I've never seen in average patients. So we taught these averages, but actually it's very patient dependent, and you have to be very careful with all these fixed numbers in introducing them into your clinical pathway through revision surgery especially. So this is just a clinical case with a correct restoration of offset, nice balance, good joint line, and a well-functioning implant. So revision surgery is challenging. Determine your femoral size based on the ML dimensions. Don't overhang, of course. Set your flexion gap and copy that flexion gap into extension, and of course, increase the constraints if necessary. Thank you very much for your attention.